first patient came in June. This was a 48-year-old Pacific Islander patient who came in with a 12-hour history of epigastric pain. He has had type 2 diabetes for the last 8 years and also known to have hypercholesterolemia. He does not have any family history of hypercholesterolemia, and he is on the top doses of glycoside, atorvastatin, and even metformin. He consumes minimal amounts, 2 units of alcohol per week, and smokes 10 cigarettes a day. The overwhelming feature of this patient was the look of his blood sample. It looked like this in ED. His body mass index was 30, and his waist circumference was 44 inches. And anything more than 40 inches is considered obese for males, and BMI 30, that's in the obese category. He had a tender epigastrium with no hepatosplenomegaly, and no algenes, and no xanthomas. Looking at his abdominal CD because of abdominal pains, I would like to point out this structure here. The radiologist said this structure, which the mouse is showing, is a pseudocyst. And the radiologist also thought there was increased stranding in the head of the pancreas and slightly larger size of the pancreas in keeping with pancreatitis. And that was confirmed in his lipase levels, which were more than 3 times the upper limit of normal. His venous glucose was abnormal at 18, so were his anion gap and his serum cholesterol, and his HbA1c was extremely poor at 16.7%. He also had microalbuminuria. But one can't help noticing the triglyceride levels, which came back when someone asked for cholesterol at 111. Normally it should be less than 1.5, so it's almost 100 times above normal. Then we thought, is this the first time, or has he had high triglycerides in the past? And we went through blood samples in January when he came to have a nail bed debrided, and someone also picked up high triglycerides at 54. So we want to know what's the normal range of triglycerides, and 1.5 is the normal range, but what's considered borderline high, 1.7 to 2.2, and what's considered very high, 5.7. So that's at least 20 times what we consider as very high. We'll move on to the second patient because they both had the same result. The second patient very innocuously presented to Kerwin Hospital Diabetes Clinics on a Thursday morning with triglyceride levels of 87. He comes every 3 to 4 months for his diabetes reviews, and he was a 48-year-old patient with type 2 diabetes for 4 years, and he was on insulin. He already had xanthoma deposits for several years, as he puts it, over the extensor aspects of his knuckles, his back, his knees, his elbows, and heels. But they seem to have gone more increased in size for the last 4 months. He was also known to suffer from hypertriglyceridemia, and his triglyceride level in the past was 49 in 2007. He's not had any family history. And the medications he was on, this time here's a patient with a specific medicine for high triglycerides, gemfibrozil, which is a fibrate. I'll come to it very soon. He's on atorvastatin and fish oil, which also has benefits in this condition. And he's on insulin. Looking at his knees and elbows, we could see those xanthomatous deposits clearly shown. So both patients got admitted, one in June through ED, the other through clinic in July, and both of them received intravenous insulin. And I'll come later to how it works. The first patient, the Pacific Islander, his triglycerides fell from 111, and just 3 days later, on the 8th, it fell down to 5.8. So we stopped IV insulin after only 3 days. So IV insulin dropped his triglycerides, and we put him on subcutaneous insulin, and he was discharged for the first time on insulin on the 15th, which is about a week later, with the triglyceride level of 10. As for the second patient, he too got admitted, he too received IV insulin, and his triglycerides also fell with the help of IV insulin from 87, 5 days later to 18, and so we stopped his intravenous insulin, put him back on subcutaneous insulin, and sent him home. The first patient, his abdominal pains resolved after day 2 of the admission, and he was discharged on gemfibrozil. And the second patient reported decrease in size of xanthomas, but we changed his gemfibrozil to fenofibrate. Now, what are these medications, gemfibrozil and fenofibrate? They're all fibrates, and I'll come to how they actually reduce the cholesterol in later slides. So here are 2 patients with very high cholesterol levels. And before we talk about cholesterol, let's briefly restructure what a lipoprotein is. So lipoproteins are structures which carry a cholesterol around their circulation. This cholesterol molecule and triglycerides are very hydrophobic. So they need to be packaged inside a particle that can carry inside something which is hydrophilic like your blood. And lipoprotein consists of phospholipids, which are phosphorus and lipids on the outer core, and proteins called apoproteins. So this is the outer core, and inside the triglycerides and cholesterol is packaged. Now, we have different types of lipoproteins. They vary in size on their density. So you know, low density, high density, very low density. So they differ in size by density. And it so happens, each one of these also differ with density, also have a dominant apolipoprotein. So apoproteins are these proteins on top of lipoproteins in the outer shell. And each one of the different densities of lipoproteins have a dominant apoprotein. And the next slide tells us which is which. So you'll find more of ApoB48 in chylomicrons, which is the apoprotein, the dominant one. You'll find ApoE in VLDL and intermediate density lipoprotein, which is the dominant one. Not to say that they don't have ApoB100, they do, but the dominant one being ApoE. And this is important for the very next few slides I'm going to show you. The next slide over here is to illustrate how the triglycerides circulate in your body. So your very low density triglyceride molecule contains a lot of this red substance, which is cholesterol, and this yellow substance, which is triglycerides. Now, this molecule circulates around your circulation, and there's an enzyme called lipoprotein lipase within the epithelial and capillary structures which surround your muscles and your fat tissue. Lipoprotein lipase is going to break down this triglycerides into fatty acids, and then they get reconstituted into triglycerides and stored in your fatty tissues. And that's how the fats get stored in your fatty tissues. In fact, 1/5 of each and every one of our body weights is actually triglyceride. And it can produce 574,000 kilojoules of energy. That's enough to sustain you for 3 months. In comparison, glycogen only provides you 2,400 kilojoules of energy. So it's a very, very rich source of energy which is stored in our fat tissue, which is triglycerides in this way. I also mentioned lipoprotein lipase being present in the muscles. What does it do in the muscles? It takes the triglyceride into muscles and it burns it up, so that's how you get energy to do your daily activities. And what happens to the VLDL molecule after it has surrendered a lot of its triglyceride tissues? It becomes smaller and it gets converted into an LDL molecule. So, Algenes here. So the triglycerides, the triglycerides taken up in your muscle tissue by lipoprotein lipase get burned up, and the lipoprotein VLDL gets converted into LDL, which is nothing but a VLDL molecule that has surrendered a lot of its triglyceride. And why has LDL got the bad name, bad cholesterol? Because it has 9 times the half-life of VLDL and stays in your circulation 9 times longer. And the danger is it can surrender the more of the red portion, which is cholesterol, into your atheromatoous plaques and therefore worsen your atheromatoous disease, so worsen coronary artery disease, and worsen your peripheral artery disease. And that's why LDL is a bad cholesterol. In comparison, HDL is a good cholesterol because it's produced by the liver. It goes on to the circulation and mops up the cholesterol and takes it back. So before we go into genetic cause of hypertriglyceridemia, let's talk about some acquired cause of hypertriglyceridemia. And did our patients have any risk factors of these? Yes, the first patient was obese and he also had diabetes, which was poorly controlled. And the second patient had diabetes but was not obese. There are other causes which can cause hypertriglyceridemia, such as pregnancy, or estrogen, or beta blockers, or even HIV medication or immunosuppressants. How does diabetes cause hypertriglyceridemia? It inactivates lipoprotein lipase. And that's the enzyme that is supposed to do its job and take your triglycerides from your VLDL into the fat tissues and into the muscle tissue. So diabetes inactivates that enzyme, so it can't do its job, and that's how it's believed your triglycerides go up. And diabetes also says it pushes out too much of free fatty acids from the fatty tissues in the circulation, and that's how your cholesterol and triglycerides go up. Very briefly, we're going to touch about gene studies. I'm going to talk only about 3 gene studies. ApoE. Now, remember the structure of the lipoprotein molecule I showed you? That's one of the apolipoproteins. And ApoE gene studies, 64% of us, assuming we're all normal, we should have ApoE3. copies. But in the abnormal form, ApoE2, you get type 3 hyperlipoproteinemia, where you have very high triglycerides and cholesterol. But this disease has been picked up as a teenager. So the patient was presented as a teenager and got picked up and treated. So you should not present in your 5th decade of life like you did in the Pacific Islander patient. So in all likelihood, he did not have it. And yes, we sent the gene studies to Royal Brisbane and it turned out to be negative. Lipoprotein lipase gene. This is another condition. The previous slide we spoke about familial dyslipidolipoproteinemia. This is different. This is familial hypertriglyceridemia. And if you have an inactivating mutation of the lipoprotein lipase gene, again you can have high triglyceride levels. Unfortunately, Queensland Health only tests for the ApoE gene and do not do lipoprotein lipase gene. And there is a lab at Perth that does a lipoprotein lipase gene. It's the only one in the country. But again, it should be done only for very selected patients. Now we'll talk about something more common, combined hyperlipidemia. So combined hyperlipidemia is a very commonly occurring form of hypercholesterolemia, and its incidence is 1 in 200. And almost 1 in 5 individuals who develop coronary artery disease before the age of 60 have this disorder. And that's by definition premature coronary artery disease. And it has very high triglyceride levels in this condition, and it can cause atherosclerosis. And it's of two forms. The combined hyperlipidemia could be familial or acquired. And familial is caused by overproduction of yet another apoprotein, the ApoB100. And when you have too much ApoB100, your clearance mechanisms are saturated, and it cannot get cleared up as quickly, and it persists in circulation longer, and so you get high triglycerides by this mechanism. And it's quite a common disease, 1 to 2% of the general population. So in all likelihood, many patients in the cardiology wards with premature ischemic heart disease before the age of 60, they're quite likely to actually have this condition. And if you take a family history, you should get a positive family history in this condition. We'll move on to acquired, and this merely means that you have a secondary cause which is caused by high triglycerides. And the previous slide I showed a list of secondary causes, one of them being diabetes, another one called obesity. And when you combine all this together, you get a syndrome called metabolic syndrome X, which is high diabetes, hypertension, obesity, high triglycerides. And in this condition, that's what's called acquired combined hyperlipidemia. And it's believed to be diabetes pushing out too much of fat from the fatty tissue, and diabetes inactivating lipoprotein lipase, so not taking fats into the fat tissue. So we contacted Royal Brisbane, and he told me the gene studies were normal for the first time. And he says we don't do any other gene studies besides this in Queensland Health. And he says why he does not do gene studies for high triglycerides. And this is an actual transcript of his email. It says, the major issue with genetic testing of adults with high triglycerides is the lack of well-established genetic etiology. And you have to do familial studies to identify more common disorders like familial combined hyperlipidemia or familial hypertriglyceridemia. And genetic testing as of 2011 hasn't yet entered into clinical practice for high triglycerides in the adult population. And he says the cost of this test is $292, and that's the only one they do. So I asked around the other endocrinologists, and I got a response from Cairns, and that doctor sends high triglycerides, lipoprotein lipase gene studies, and several other gene studies for familial causes to Perth. So that probably is the other way of getting these tests done. But again, funding has to be considered for this. But in any case, we don't routinely do any genetic testing for high triglycerides because it hasn't yet entered into our clinical practice just as yet. Very briefly, what are the physical signs you would expect in someone with high triglycerides? So you saw in one of the patients xanthomata, so that's one of the signs, and they appear as yellow papules in the extended surfaces of your arms, legs, buttocks, and back. Or they could have hepatosplenomegaly, and you could have fatty liver on the ultrasound. Or they could have lipemia retinalis. If you look into the by fundoscope into the retinas, you could find lipemia retinalis sign. And they could also present you with pancreatitis. And it is said that any level about 25 to 40 of triglycerides puts you at risk of pancreatitis, theoretically. Although, as in medicine, you can have people with triglycerides over 100 and not having pancreatitis. And management of high triglycerides. First thing is to do the basics right, just like you would do with any other patient with diabetes, we just send them to a dietitian and get the diet control and get rid of the obesity and ask them to lose weight and exercise. And alcohol is also a risk factor for secondary acquired hypertriglyceridemia, so we get them to stop their alcohol consumption and regular physical activity. And that way you can overcome your insulin resistance and you can optimize your glycemic control. Now what about statins? Statins can interestingly also lower your triglycerides, just like it does with cholesterol, but when the levels are 111, it's too weak and it can't really bring it down. Another important part of managing these patients is exclude secondary causes. So if we find the patient drinks excessive alcohol, get them to stop it. And both our patients, I would say, had dietitian review just to exclude secondary causes, just to get their diet under control and just to lose weight. And when it comes to treatment, when the serum triglycerides is only mildly elevated, say more than 5, you can get away with the statin. So this is in clinics. Many of the diabetes patients, triglycerides are 7 or 8. And for them, you can get away with the statin, which is used for cholesterol. You can also bring it down, bring the triglycerides down using a statin. But not for these two patients whose levels were 111 and 87. For these two patients, we have other treatments for that. For your normal clinic patient, you can get away with the statin to start off with. And when to start fibrates and nicotinic acid, that's when your statins don't work and you have failed to bring it down to top doses of statins. And how effective are they? Statins have got a 20 to 30% decrease. It can cause decrease of triglycerides 20 to 30%. That's second from bottom of the list. But fibrates, which is what we gave our patients, one of them was put on gemfibrozil, the other one on fenofibrate. They can reduce the triglycerides by 20 to 50%. But what really impresses me is fish oil. Something so innocuous can reduce your triglycerides by 50% or more. And then there's plasmapheresis. This works in everything. Autoimmune disorders, it works. In graves, it works. And it's also working here in hypertriglycerides, 70%. So that's really the best treatment we have got. Now here's an evidence-based question. Can high triglycerides cause you to have coronary artery disease? And will reducing it make your patients live longer? So we review the evidence from the JAMA, from the article at the bottom, and it says, cardiologists will also like to comment on this, that it will reduce your event-free survival after a bypass graft, after a coronary artery bypass graft, if your triglycerides are still high, and if you haven't reduced it. And if you already have coronary artery disease, it's a bad thing. It will cause more mortality compared to those whose triglycerides are not so high. But in these patients with coronary artery disease, even if you reduce the triglycerides, you're actually not increasing the survival rate, i.e. not decreasing the mortality. So the evidence, from what I could gather, says that it's going to worsen survival rate after CABG surgery, and it's going to worsen those suffering from coronary artery disease if you don't bring triglycerides low. But if you do bring it low, it's not going to make you live longer. And that's why we go to the American Diabetes Association guidelines. Now the first row of this guidelines, all of you know by heart, that you must reduce the total cholesterol less than 4 and the LDL, keep it between 2 to 2.5 or lesser to those who have high LDL and those who come to your clinics. But the purpose of this talk is triglycerides. How low should you keep it down to, given this recently discussed evidence? So it's believed you should keep it less than 3.88 according to these guidelines. And it's believed you should start treatment at all costs if the triglycerides are more than 10. But there you go. We have a gray zone between 3.88 to 10.3. And it doesn't really say what to do if the triglycerides are between 3.88 millimoles